Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with a blocked left ear, and it was quite a tricky procedure, mainly because the patient was in a wheelchair and they were not able to sit on our ENT couch and chair. And in addition, their body posture was such that their head was slightly tilted forwards. Therefore, in order for me to perform the procedure, I had to actually crouch down on the floor, and I was actually on my knees on the floor just to get the right angles. But that's why an endoscopic approach of removing earwax is so useful and beneficial, because we're able to work in such cases where there's different angles involved. And I used to perform a lot of domiciliary visits. I used to visit patients at care homes, and quite often they're either bedbound or they've got these they're armchairs, but the armchairs were the headrest itself used to almost curve around the patient's head, so the ear was almost embedded within the couch. So an endoscope allows you to work with these funny angles, because you don't have to always be in the direct line of sight of the ear. It's ideal, but as long as you can get the endoscope into the ear, and so it just means moving your elbow, your shoulder and your wrist and manipulating the endoscope with your fingers, you can work off screen. So even if you're not directly, as I said, looking into the patient's ear, as long as you've got access to the ear with the instrument and you're able to get the instrument in, you can work with these kind of sometimes awkward angles. This particular patient, this blockage was predominantly dead skin, dead keratin. They have to attend on a regular basis. They are an elderly patient, they're in their 90s, and as we get older, we're just more likely to get this skin buildup within the ear. It doesn't help because the patient wears deeply fitted hearing aids, so the hearing aid itself is preventing the natural migration of this skin out of the ear, and it may also inadvertently be pushing it further in. The reason why it's more common, this condition with elderly patients, is because as we age, the skin cells, the epidermis layer is less able to retain natural internal moisture, and that's because the ceremonous glands and the sebaceous glands are not as active, so they're not secreting the oily, viscous, fatty secretion called sebum, and an oily sweat, which is produced and secreted by the ceremonous glands within the ear. And these fatty oils and sweats are important within the ear chemistry, because what they do, they line and provide a thin veneer of the ear canal wall and the eardrum. And it's a hydrophobic veneer, a thin film that's lining the ear canal. And that helps to retain internal moisture in the skin cells. Without that layer, water and moisture within the skin cells, it rises to the surface of the epidermis layer of the skin, which is the outermost layer, and then it evaporates, causing our ears to become very dry and itchy, and we get a buildup of exfoliated dead skin cells. In addition, this oil veneer, it helps to prevent external moisture from being absorbed by the skin cells, because the skin cells do absorb moisture. They're hydrophilic. So if you've got excessive moisture within the ear canal, the skin cells can overhydrate, and then they can burst, so the membranes break down and the skin cells break down, and again it can lead to a buildup of dead skin in the ear. But predominantly in elderly patients, it's just because then you're not producing these natural oils within the ear, and subsequently internal moisture within the ear canal rises to the surface and it evaporates. Whereas if you had these oils, it prevents the evaporation of these the internal moisture, and it keeps it within the deep layers of the skin. So I'm just working on the midsection here. You can see this patient's got some ulcerations of the skin. So when we say ulcerations, we just mean the breakdown of the structure of the skin. And that could be just because this blockage has been there for a while and it's created a bit of humidity and sweat, and the patient obviously has been wearing their hearing aid on top of that. Now, that's the patient's eardrum. You can see posteriorly the eardrum is severely retracted. And please do continue to watch, because not only this left ear, but right ear, there's some interesting landmarks I later freeze and annotate. But what's happened with this patient's eardrum, it's severely retracted posteriorly, and that's meant that skin that shedded from the eardrum has got trapped within the retraction. It can't migrate. So the outer layer is the eardrum's got 3 layers. The outermost layer is made of the same skin that I'm peeling off right now. So it's the layer of epidermis skin. The middle layer is a layer of fibrous tissue, which gives the eardrum its strength and rigidity and flexibility. And the innermost layer of the eardrum is the mucosal membrane. So an example of a mucosal membrane is a skin that lines the inside of our nose. So it's secretory, it's moist, and that makes up the 3rd innermost layer of the eardrum. So because the outer layer of the eardrum is made up of epidermis skin has got the property of dying and being replaced by another fresh layer of skin, and that dead layer of skin should, once it's shedded, it should naturally migrate away from the eardrum and slowly out of the ear until eventually it's completely out of the ear. But because of that retraction pocket, the skin is getting trapped, it's not migrating. So we're going to remove that. Now, it's more of a posterior retraction pocket. I'll explain why the eardrum gets retracted in a moment, but if the retraction pocket was more superiorly, so more upwards and to the back, so in the case of this left ear, we're talking northeast, if skin gets trapped there, it becomes a lot more dangerous because it can generally then form into a cholesteatoma. It's not that it's not possible that a cholesteatoma can form here, but it's far more likely to develop in the northeast region. And a cholesteatoma is essentially a buildup of dead, exfoliated skin cells that's got trapped because the eardrum sucked in, so it creates a retraction pocket. And this skin, in most people's ears, it should naturally migrate, but in an individual's where they've got a cholesteatoma, it fails to migrate because it's got trapped. The skin accumulates, it forms into a plug, and it can grow inwards and upwards towards the brain, and it can get infected, and it can be life-threatening, can lead to brain abscess, facial paralysis. It can erode all the middle ear bones and the middle ear structures and also the inner ear structures. So it's probably one of the biggest red flags as an audiologist when we examine the ears. It's one of the first things I look at, see if there's a retraction pocket in the top part of the eardrum in particular. And if you wait until their right ear, you will see that this patient has evidence of a previous cholesteatoma, so do stay tuned. So what I'm trying to do now is remove the skin out of this retraction, and we're just going to be careful because the patient has got a very thin eardrum as well. It's a hyperflaccid eardrum, so it vibrates more than usual, and it's like peeling away an onion. You've got different layers here, and you can see I've got that thick layer there at the back, and I'm just gently just working it out of the retraction. So why is this patient's eardrum retracted? Behind the eardrum, we have got the middle ear, and the middle ear cavity should be air-filled, and the air pressure in the middle ear should be equal and at equilibrium with the air pressure in the ear canal, so the external atmosphere. And what regulates the air pressure behind the eardrum is a narrow tube, a narrow orifice called the Eustachian tube, which connects to the back of the nose. And at the back of the nose, where it adjoins to the back of the nose, the nasopharynx, the Eustachian tube is typically shut. And it's shut because it then helps to prevent upper respiratory tract infections travelling up the Eustachian tube and infecting the middle ear. And it also prevents you from hearing your internal sounds. If that Eustachian tube is permanently open, every time you breathe or talk or eat, these sounds will travel up your nose, up the Eustachian tube, and vibrate the inside of the eardrum, so you can still hear it. Sounds don't need to vibrate the outer part of the eardrum in order for us to hear it. It can vibrate the inside of the eardrum also. And these sound waves are then transmitted through the ossicles, the 3 bones, to the cochlea, the organ of hearing, where tiny microscopic sensory hair cells, then shear side to side. They produce an electrical signal which is sent to the brain, and we perceive that sound. So the eustachian tube is closed for a reason. However, during brief moments of when we yawn, swallow, or chew during the course of the day, and it's completely involuntary, the eustachian tube, the muscles either side where it joins to the back of the nose and nasopharynx, they contract, which causes the eustachian tube to momentarily open. And during those brief moments they open, the air pressure can equalise, and any fluid that may have accumulated behind the eardrum, because as I mentioned, the middle ear is lined with a mucosa membrane, which is secretory. This fluid can drain out of the middle ear via the eustachian tube to the back of the nose, and then either through your mouth or down your throat, and you may swallow it. So if that eustachian tube doesn't open involuntarily, and every time you yawn, swallow, or chew, then there's no more air in the middle ear, and any remaining air in the middle ear gets absorbed by the cells in the middle ear. And once the remaining air is completely absorbed by the cells that line the middle ear, it creates a vacuum, and when it creates a vacuum you get a suction effect, a cupping effect, and the eardrum gets sucked inwards. It's like when you're on a plane, when you're descending, or if you're scuba diving, the air pressure in the ear canal is greater than the air pressure behind the eardrum, which forces the eardrum inwards. It buckles inwards. And if it doesn't resolve, then you get a build-up of fluid as well, and that fluid can then get infected because that fluid can't drain, so it builds up behind the middle ear. It's like a water balloon. If you put too much water into the water balloon, eventually it'll pop. And similarly in the middle ear, if you have too much fluid build-up, it can cause the eardrum to inflate, and eventually, if it doesn't drain, it can burst through the eardrum, causing a perforation. We call that glue ear. So this patient has a history of eustachian tube dysfunction, eustachian tube is blocked. The right is far more worse, and they've seen the ENT, and there's not much more that can be done for the patient. It just needs to be monitored and kept on top of, and it's going to remove the skin as often as possible, as and when required. Fortunately, there's no fluid behind the eardrum. We did test that. So the eardrum's fully visible. I am going to put an arrow in a minute so you can see where the eardrum's sucked in. It's just a bit of skin centrally. I just want to see if that peels away. So you may be able to see the rim where the eardrum's sucked in. So it's quite a deep retraction pocket. It's not often you see that part of the eardrum retracted. I said normally it's in the attic, the top part, and you'll see that in the patient's right ear. So I'm now just trying to remove as much skin as possible. Again, we're very deep in the ear. It's going to be very careful that we don't make contact with the ear canal, because that would be uncomfortable for the patient. The patient will need to attend again I think it's been 5 months, so it's almost 2 or 3 times a year they have to attend. Again, it's not possible for us to remove every little aspect. Not only is it not possible, it's not also practical, is that patients having to, as I said, they are quite an elderly patient, and they're sat in an awkward position in their wheelchair. And myself as well, I'm in an awkward position, so I've got to bear probably less than my comfort, but the patient's comfort as well. So we're trying to remove as much as we can, efficiently as possible, so it's comfortable for the patient. And we've still got the right ear to do as well. The right ear, there wasn't as much debris, but it was a bit more challenging, the right, because if you think this lateral part of the ear canal is narrow, the right one's even more narrower. Once you get past the outer third of the ear canal, the bony part where we are now, it's a lot wider. It's become more of a normal sized ear canal. It's just the outer third that's very narrow, and it's very likely that the canal has collapsed as we get older. Again, the cartilage of the ear canal weakens, a bit like the tip of our nose. The cartilage weakens. So the nose, the bottom 2/3 of the nose is made up of cartilage. The upper third of the nose is made up of bone. The ear canal is slightly different. It's only the outer third that's made up of cartilage, and the inner 2/3 is made up of bone. And gravity over the years will take its effect. Cartilage is not strong as, it's not as rigid as bone. Eventually it'll weaken, and gravity can take hold of it, and the cartilage can collapse. The cartilage in the ear, the posterior part of the cartilage, can also continue to grow, and it can extend outwards, and when it extends outwards, it hasn't got enough support, so that can also cause it to collapse. So sometimes there is surgery where you can trim that cartilage and almost strengthen that scaffolding. We call that a canaloplasty or myotoplasty. And I think we're more or less done. I just want to make sure there's no canal cholesteatoma. Sometimes you can get a formation of dead skin that it can get trapped in some of the ulcerations of the ear canal, the base. You can see there's lots of dead skin there. It can cause a crater or pothole, and skin can fall into that. And again, similarly to a traditional cholesteatoma, a canal cholesteatoma is far more rare. A cholesteatoma in itself is quite rare. It's not something you see every day. But a canal cholesteatoma is even far more rarer, and that can then infect the bone. It can start eroding the bone, the floor of the ear canal, and that infection, once more, it can spread all around the ear, to temporal bone. It can affect the jaw. It can affect the mastoid process, which is the bone behind our ear. It can go upwards towards the brain, and it can also erode and infect the facial nerve, the seventh cranial nerve, which runs in the middle ear. So I just wanted to make sure the patient doesn't have a canal cholesteatoma. They don't. So this is their right ear, and this is far narrower. This is far more tricky. So the patient's head was not only tilted forwards, downwards, but it was also tilted slightly to the right. So I'm kind of having to look upwards in this case, and it was quite tricky at times to kind of get the skin out. And because of the narrow ear, it's very little wriggle room with the instrument. I'm trying to pull this skin away from the canal wall, but when I'm going away, so in this instance the skin is on the left hand side of the ear canal, as I'm trying to almost drag the skin to the right, more to the midline, you've got to be careful, because if you overdo it, the fine end suction probe will bounce up against the right hand side of the ear canal, being comfortable for the patient. From the cartilage portion it's fine, but we're now on the bony part, so you'll be very gentle. So again, I'm trying to remove as much skin for the patient as I can, because the skin is unfortunately just not going to migrate on its own for the patient. And this ear was severely retracted. Now, it was so retracted that the back part of the eardrum, the posterior section of the eardrum, had been pulled in so much that it had wrapped itself around the hammer bone, the malleus, and when it did so, it constricted all the blood vessels supplying blood and nutrients to the hammer bone, which has then caused the hammer bone to erode, especially the short process. The short process is the top part of the hammer bone. So you can see the patient just moved there. We're peeling the skin. It's slightly uncomfortable. I think it happens a couple more occasions as well. So the short process is at the top part of the hammer bone, and it somewhat protrudes outwards of the eardrum itself. So when the eardrum gets sucked in, that's a very prominent part of the hammer bone that the eardrum wraps itself around. So it squashes the blood vessels, it constricts them, and the blood can no longer supply oxygen and much needed nutrients to the bones. The bone can start necrosing, can start diseasing and eroding away. In addition, the eardrum had got so sucked in that it wrapped itself around the long process of the incus. So the incus is the middle bone, also known as the anvil, and it had wrapped itself around that, and similarly it had strangled the blood vessels, it constricted them, so the incus eroded. So this eardrum, and you will see it, it's wrapped itself around the head of the stapes. So the stapes is the smallest bone in the body. It's the third middle ear bone, the last of the three, and that's connected to the incus. But the incus is no longer visibly there. So at the juncture, the incostapedal joint, where the incus would join with the head of with the stapes, we call that the region the head of the stapes. The head of the stapes is now visible because the eardrum sucked right around it. And in addition, this patient has got erosion of the top part of the ear canal near the eardrum. We call that the scutum area. So because the eardrum's been sucked in, that piece of bone, it's almost like an overhanging piece of bone at the top of the ear canal. As I said, it's called the scutum. The blood vessels there have become constricted, and that's resulted in the bone, the scutum, to have died and eroded, which has left the patient with a widening, a big vacant area at the top part of the eardrum. We call that an autoatticotomy. Sometimes if a patient's got a cholesteatoma, that's the region where the cholesteatoma forms. So that's the head of the stapes bone I was referring to. So the eardrum's sucked right in, it's wrapped itself around that. And I'm just angling the endoscope upwards. You can see that missing part of bone, that's where the scutum normally is. And that's where cholesteatoma can normally form. Fortunately, there's no cholesteatoma there. The skin does manage to migrate outwards, but we call that an autoatecotomy. Sometimes an ENT surgeon will have to drill that bone away, and that procedure is called a tympanoatecotomy. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.